Hi everyone, today we're going to be talking about stress and coping. Hi everyone, today we're going to be talking about stress and coping. I feel like much of this information will be a review to you based on everything that you learned in Nursing 131. So we'll obviously dive a little deeper in many of these drugs, but like I said, it'll probably be very familiar to you, not only from 131, but from the administration of many of these meds that you guys do in clinical. So let's get into it. Psychological states affected by anxiolytics and hypnotic drugs. So we're going to talk about anxiolytics, hypnotics today, sedatives. So let's talk about what is anxiety. I don't think I really have to review that in depth with you guys. It's the feeling of tension, nervousness, apprehension, fear involving unpleasant reactions to a stimulus. Haven't we all felt that way? Some of us have situational anxiety. Some of us have anxiety that kind of runs in our family, definitely genetic. And some of us just have anxiety based on stressful situations that arise that we can deal with either pharmacologically or non-pharmacologically or both. Sedation. What is sedation and why are we using sedatives? It's a loss of awareness in reaction to environmental stimuli. I'll go into this a little deeper in the next slides. And then hypnosis, extreme sedation resulting in further CNS depression and sleep. So as I just mentioned on the previous slide, we're going to go through sedatives today. And what do sedatives do? Calm and make patients aware of the environment. Those are used in many different situations, but in the hospital, we're talking procedural mostly, colonoscopies, endoscopies, EGDs, procedures at the bedside, even an IND sometimes. Hypnotics cause sleep, and minor tranquilizers produce a state of tranquility in anxious clients. Like I said, we'll go into depth more about that. So let's start talking about anxiolytics, benzodiazepines, right? Or benzos, many of us know them as just plain old benzos. The prototype that we're going to discuss first is diazepam. Valium is the trade name, so that's pretty interchangeable. I always say better known as, in this situation, both names of this med are very familiar by our patients. So indications for diazepam: anxiety, acute alcohol withdrawal, pre-op or endoscopic sedation, muscle spasms, seizures, tetanus. Somebody comes in with tetany. They have lockjaw and just a full-on tetany. We'll give them some Valium for that. And what is the action? Benzos potentiate the effects of GABA. They depress the CNS, suppress the spread of seizure activity. All right, next slide. What are the ADRs of Valium? Well, mostly bradycardia and respiratory depression, apnea. Diazepam's been around forever, so the ADRs are fairly not rare. They don't happen often. I would say the times that we see ADRs with Valium is when it's being taken in conjunction with other medications. I'm not going to go into contraindicated meds for this, but that's typically when we see bradycardia and respiratory depression mostly. All right, next slide. So continuing on with our talk about diazepam, Valium. So the nursing assessment, we want to assess for the history of substance use disorder. We want to get a baseline liver and kidney function. As many of the drugs that we're talking about, we know that where are meds metabolized in the liver, where are they excreted in the urine. This is why we're getting the baseline functions, baseline status. So we want the vitals, we want the affect, we want orientation, we want refluxes, because we know that it's going to take a hard hit on the CNS. So we want to make sure that they're not already starting out with a baseline of very depressed CNS. Client education, I think because of this, caution of opioids, we want to avoid alcohol. That goes back to the CNS effects. COM side effects again, drowsiness, You'll have blurred vision. Blurred vision is very common with Valium, so it's almost an accepted ADR, especially if patients are in the hospital. But if they're taking Valium at home, you want to let them know that if they are having blurred vision, that they should probably discontinue and talk to their provider about that, especially if they're driving. So they may have some confusion, dry mouth, definitely that's very common. Hypotension, again, we're just being aware of those vital signs, and that blood pressure, even going back to the blood pressure, I would educate our patients too with the potential for orthostatic hypotension. So they can be dizzy, when they're waking up in the morning, if they've been taking Valium for a few days, just to be really cautious, sitting up on the side of the bed for a couple minutes, kind of getting their sea legs a little bit before they get up and start walking, because we do not want them falling, so they're an increased risk to fall even at home. Okay. So the next anxiolytic that we're going to talk about, the next benzodiazepine, prototype is lorazepam, also known as Ativan for the trade name. Again, those names are pretty interchangeable in the hospital, or patients know both meds both titles of the med pretty commonly. Indications for Ativan. Gosh, there's many, even more than this, but we're going to go through like the 5 major indications. So for anxiety, alcohol withdrawal, insomnia, related to stress, anxiety, of course, pre-op, going back to insomnia, like my conversation with you guys back a couple lectures ago about propofol. I mean, many people have insomnia. We don't want anyone taking propofol for insomnia. I mean, that goes without saying. Melatonin, sure. Have I found that melatonin works for the one time that I tried? No, but if it works for you, we see it more and more being ordered for our patients in the hospital. But in this case, these are situational, PTSD, a death, a tragic death. Sometimes you'll see a doctor order Ativan just on a very short-term basis. All right, pre-op sedation, very common, and status epilepticus, very common, okay, especially in IV form. We have 1 milligram ready IV if somebody's having a seizure. We have another IV 1 milligram waiting on a backup. So that's very common for seizures. Action, it potentiates the effects of GABA, depresses the CNS, and suppresses the spread of seizure activity, again, going back to the status epilepticus. All right. Okay, sorry about the whoop whoop. I went ahead too far in this lecture, and they're in the PowerPoint, and it wouldn't let me go back. So, ADRs for patients taking Ativan, you will see the potential for respiratory depression. Again, that goes with the dosage, and also what other meds are they taking, and what's going on with the patient, obviously, as well in the clinical picture. Is their CNS already depressed, and we give them Ativan, and then they go right into respiratory depression. So going back to vital signs, not just for the blood pressure, but we're definitely looking at that respiratory rate. So I know many of you guys listen to this lecture when you're driving or doing something else. You got your little AirPods in. But on this particular slide, we have just a little chart of the 5 really most common side effects of Ativan, and it really kind of goes hand in hand with our previous benzo. Valium, you'll see drowsiness with Ativan, dizziness, weakness, fatigue, restlessness too at times. Again, that goes back to what we've talked about, the paradoxical effect on some of these meds. It's the opposite of what we expect. We don't want somebody to feel restless when they're taking Ativan, so let's just be mindful of that and keep an eye on that assessment. Okay, so again, very similar to Valium. Our nursing assessment will look at the H&P, especially when we're doing our admission assessment, look at the history of substance use disorders, baseline liver and kidney function, baseline patient status, especially regarding the CNS status, client teaching, caution use with opioids, avoid alcohol, and common side effects, again, drowsiness, blurred vision, confusion, dry mouth, and hypotension. Very similar to Valium, so it'll be easy to study this. Okay, so we've talked about Valium, we've talked about Ativan, now let's talk about Xanax. All very familiar drugs that we've given, right? And they're all very similar in their indications, all very similar in their nursing assessments, client education, and ADRs. So like I said, it's pretty straightforward, this information is. So indications for Xanax, anxiety, panic disorders. What is the action on Xanax? It potentiates the effect of GABA, depresses CNS, and suppresses the spread of seizure activity. You see how similar this is? I'm sorry, this is probably boring, you guys. This is a very quick and somewhat boring lecture. All right, so the ADRs of Xanax, little different. What was the ADRs on our previous two? Respiratory depression mostly, right? We don't see that so much with Xanax. With Xanax, short-term, especially long-term use, we'll see the high risk for suicide, all right? And definitely the high risk for CNS effects as well. Not so much respiratory depression, but you'll go in, and if somebody is popping Xanax like Tic Tacs, which they do, and we still see providers readily ordering Xanax for our patients, that we can definitely see the high probability of CNS effects if they're taking too much Xanax, okay? But otherwise, looking at this chart on this slide, similar to the Ativan, here's the common side effects of Xanax: drowsiness, lightheadedness, fatigue, impaired coordination, depression, headache, increased salivation. If I haven't mentioned it, there's, with the client education, we definitely want to tell them to be cautious when they're driving. I think some providers, when they're ordering some of these benzos, say that they don't want their patients driving at all. And I don't know how compliant our patients are with that, but it, kind of goes without saying, especially how it affects the CNS effects. All right, so the nursing assessment, if our patients are taking Xanax, alprazolam, history of substance use disorder, baseline liver and kidney function, baseline status. You want to jazz it up and put something different, but I'd be remiss if I didn't kind of keep this aligned because it is all so similar, just with a few little different nuances here. So client teaching: avoid alcohol, opioids, avoid use in pregnancy and breastfeeding. That's a biggie with Xanax. And common side effects: drowsiness, blurred vision, confusion, dry mouth. And what is probably one of the biggest things with Xanax, client education, is we're talking with them about how they're feeling, okay? Do you have any suicidal thoughts, any suicidal ideations at all? Are you feeling depressed? Now you can say, well, you didn't say depression. No, but the way a patient might describe that is, I just don't feel like living anymore. Now, those are suicidal ideations rather than depression at times. Okay. All right, so lifespan considerations. What do we have to consider when we're talking about any of these benzos being administered to children, adults, the elderly? All right, so children, that's where we'll see the paradoxical response. And we're talking benzos in general. They're really not recommended for patients less than 18 years old, especially Xanax. Adults, short-term use. We know, unfortunately, that is not the case for many of our patients. They come in saying, I've been taking Xanax for years. Can you please put me on Xanax? So that's just something to consider. Elderly, very susceptible to ADRs. Why? It's hard when I'm recording because I'd like to hear your responses, but it goes back to how is their liver function? How is their kidney function? Again, going through metabolism by the liver, excretion by the kidneys. Most of our elderly patients have some compromise, especially kidney function. So we want to be aware of how their labs look. And benzos are not generally used in patients over 65, except for when they come in. ETOH withdrawal. What do we do with our patients when they're coming into the hospital with ETOH withdrawal? We could either give them Valium. We do give them Ativan. We're following COWS, we're following GMAW, and we're just being prompted by the assessment when we're doing that at least every 4 hours, if not more often than that. Okay, and then we can take a look at our herbal supplements. We'd be remiss if we didn't include this because many of our patients are really looking at the comprehensive care of what's out there, holistically especially, and they're also being educated by their providers. Many of them have clinical nutritionists in the office as well that make recommendations for herbal supplements in conjunction with pharmacological treatment for anxiety. So chamomile, what is chamomile? It's used for anti-inflammatory, sedative, antispasmodic. Many patients say, I drink 2 cups of chamomile tea every day. I've had anxiety for years, and I really feel like that helps. The other herbal supplement that we're starting to see, not starting to, but we've been seeing here and there on the NCLEX is kava. So kava is an anxiolytic, muscle relaxant, insomnia. I'm not going to go into the history of where kava comes from, but it's good to know that it is contraindicated in hepatic disease. All right, if somebody already has hepatic disease, the kava takes a lot to metabolize in the liver. So if the liver is already compromised, then kava is contraindicated. Contraindicated in Parkinson's disease, depression. It may potentiate other sedating medications and anticonvulsants. And that's also something to keep in mind too. If a patient comes in and they had been taking Xanax at home. Oftentimes these patients have, I don't know why I'm whispering because I feel like it's like a little sensitive topic, but oftentimes these patients have a little bottle of Xanax in their purse or in their patient belongings. And if they're feeling a little anxious, they're not going to ring the bell. They just reach over to their patient belongings, pop a couple Xanax, and they feel better. Now, in the meantime, we have Ativan that has been ordered on their MAC. And if we feel like they're feeling anxious, we talk to the patients, we do our assessments, we ask them if they want anything in addition to help them with their anxiety. They say sure. We bring in Ativan. That's just those two combined, as with any others, it's going to really intensify the CNS effects. So that's just good to be aware of as well. Ask them if they've been taking Xanax or any other medications at home to help them relax so that we're not doubling up, tripling up, and causing especially respiratory arrest, that starts with respiratory depression. Okay, and I think that wraps it up with stress and anxiety. We're going to head on to mood and affect.